Hello, everybody, and a very warm welcome to my presentation on World Schema Therapy Day, titled Deepening Imagery Rescripting in Schema Therapy Using EMDR, an Integrative Approach. I am Dr. Priya Puri. I am a clinical psychologist based in India. So, if we look at schema therapy as well as eye movement desensitization and reprocessing, they are both empirically established therapeutic approaches to deal with complex trauma. And both the approaches help in reprocessing traumatic memories. They have some similarities as well as some differences in the way in which they help an individual reprocess traumatic memories. And we will be seeing the similarities as well as the differences of these two approaches. And we will also see how we can integrate both the approaches in certain ways and get uh, good results with our clients. Now, what are the similarities in the reprocessing work of schema therapy as well as EMDR? Both the approaches use floatback as well as affect bridge, right? So in EMDR, it is known as floatback, and in schema therapy, we call it affect bridge in order to access childhood memories. So whatever the present concern is, that present concern, the emotions, the thoughts, the beliefs, or the negative cognitions, the somatic sensations, the bodily feelings, right? All of that is used to go back into the past and access childhood memories. And in EMDR, it is known as floatback, whereas in schema therapy, it is called affect bridge. Another similarity is that both the approaches activate the memory before reprocessing it by making the client recall some of the vivid aspects of the memory, which include emotions and bodily sensations. And this helps to bring the memory to the bring that particular memory, it activates it and brings it to the working memory. So in schema therapy, the method that we use is we ask the client to narrate it in present tense in first person. That is how we go about it. And we ask them to give vivid components of the memory. For example, the room they are in and what are they able to see? What are they smelling? Are they able to hear something? So to activate the senses. And in EMDR also, the memory is activated. It is brought to the working memory by a very specific set of questions, such as what is the worst image that represents the memory? What are the emotions they are feeling? What are the negative cognitions? So both the approaches make the memory very palpable and bring it to the working memory state. Both the approaches look for schemas as well as negative beliefs that are associated with the memory. And EMDR as well as schema therapy, both the approaches believe or go with the paradigm that the older the memory, the deeper its impact is in the formation of the negative belief. So in schema therapy also, we try to look for the earliest memory. And it is the same in EMDR. And the earliest memories are known as touchstone memories in EMDR. So both the approaches have a significant amount of things in common. Now, what are the differences in the reprocessing work? How they differ in reprocessing? Now, in schema therapy, the therapist plays a very proactive role in the imagery rescripting, right? So the therapist asks probing questions to the child self of the client to understand the needs of the child self, right? To understand the needs of the vulnerable child, that what do you need? What do you want me to tell mom? So there are probing questions that the therapist asks the vulnerable child. And the therapist may also enter the image, right, to help the vulnerable child get its needs met. The therapist may enter the image, be with the child, express compassion to the child. The therapist may also have a confrontative dialogue with the perpetrator. The therapist may enter the image and actively try to protect or support the vulnerable child. And this thing, the fact that the therapist is allowed, yes, there are scripts where the healthy adult self also enters and talks to the vulnerable child, has a dialogue with the perpetrator, but that's usually in the later stages when the healthy adult has been strengthened adequately. But in the initial stages of schema therapy, usually in imagery rescripting, the therapist enters and does a lot of proactive work. And this, as a schema therapist, I feel that this is in line with the limited reparenting paradigm, right? Wherein, of course, the memory is getting processed, the memory is getting reprocessed. There are new neural pathways that are being created with respect to the memory, but the client also feels supported, protected, and validated by the therapist, right? So the experience is not a lonely experience. The experience is with somebody. And this in turn can foster some secure attachment in the client. The client may say that I feel supported, I feel seen. These kind of experiences usually clients share after an imagery rescripting session. I feel that somebody is standing up for me. I feel that somebody really cares about me. So this fosters secure attachment in the client. And in schema therapy, the therapist also has room for creativity, right? The therapist can be creative with the imagery work that they do. So schema therapy, it's not like we do have templates, we do have certain guidelines and templates, but it is not like we have a predetermined script. It depends upon the image, and we are allowed to be creative with the uh, imagery work that we do. And from my experience, I have seen that because the therapist proactively enters the memory, shows compassion for the vulnerable child, and confronts the perpetrator, usually uh, the one memory, the one memory can usually be reprocessed in one single session with schema therapy. I'm not saying that the memory will 100% get reprocessed, but the cycle of reprocessing, that entire cycle can be completed in one single session with schema therapy. It is not like we have to leave some part of the cycle and continue with that in the next session. Schema therapy requires the therapist to be very intuitive. We have to be quite intuitive. We have to be quite attuned to the client and uh, detect what what are the right probing questions, because there are guidelines, but it is not like we are given absolutely scripted probes. We have the liberty to create our probes, and we have to be intuitive, we have to be attuned to the client. And sometimes when we are confronting the perpetrator, of course we ask the vulnerable child, but there's also some element of our own healthy adult a self that we use in order to talk to the perpetrator. So, schema therapy requires the therapist to be intuitive, to be very attuned with the client, and does not really have a predetermined fixed script for the imagery rescripting exercise. Like I said, there are templates, but we can choose how we want to frame our words. And the schema therapy imagery rescripting has a very deep impact on the client's attachment system. Like I said before, it has a very deep impact on the client's attachment system because the therapist is entering the image to support the vulnerable child and to confront the abuser. Or even if the healthy adult of the client enters the image, the therapist can also enter the image and be there, right? So there's a big impact on the client's attachment system, and we know that schema therapy is actually highly attachment informed. It has got its roots in the attachment theories. Now, when we look at EMDR, in EMDR, the therapist just asks some questions, particular questions that are given in the manual to activate the memory. And after that, the therapist does not enter the memory or come in the way of reprocessing. And the client's brain is completely allowed to take charge. The adaptive information processing network, which is a very core aspect of EMDR, so in EMDR, it is believed that the adaptive information processing network will take charge, and that will take care of the processing, that will take care of wants to, how the client's brain in an adaptive way wants to navigate with the memory. So the therapist fully allows the client's brain to take charge and just asks the client to notice the material as it is coming up. So the memory is activated, paired with bilateral stimulation, and the client is just asked to notice the material as it is coming up until the memory gets completely neutralized. So the therapist plays the role of a facilitator, not the role of somebody who enters the memory along with the client or enters the memory and proactively helps in reprocessing. And the reprocessing is very categorically divided into 5 phases, phases 3 to 7, and I will briefly touch upon these phases as well. So it's very categorical, very specifically divided into phases. Target assessment. So phase 1 and 2 are where we are trying to, so in phase 1, we try to do target identification, where we are trying to understand the presenting problem and trying to, like, make a list of the memories that are associated with it. And then in phase 2, we introduce them to how EMDR works, etc. We try to tell them about what are the different types of bilateral stimulation that we would be doing. We make them practice the bilateral stimulation, and then we also do stabilization work and see what is the kind of stabilization and resource building that the client requires. So phase 2 is all about regulation, stabilization, building resources. Phase 3 is where phase 3 onwards is where the reprocessing work happens. So from phase 3 to phase 7 is where the reprocessing is done. So phase 3 is target assessment, phase 4 is desensitization, phase 5 is installation, phase 6 is body scan, and the last phase is closure. I think I missed writing that over here. Oh, I've written it. Phase 7 is closure. And the whole process of reprocessing a memory is very categorical, and the manual very clearly gives like specific guidelines of what to do, when, how to go about the reprocessing. It's like very, very specifically stated, and we just need to follow the manual. It is not like there is no intuitive component over here. There is intuitive component here as well, but still it is extremely structured, very, very manual based. Now, the reprocessing of one memory may actually take more than one session because of the multiphasic approach, and also because the therapist is not entering the memory and speeding up the process. So the client's brain does the processing work, the memory starts shifting. And sometimes, if the memory network is a very old network, it's a complicated network with many aspects, many memories, then the processing can become slower. In fact, I have sometimes, in my usage of EMDR, I have sometimes seen that one single memory can also take maybe 3 sessions to get reprocessed, starting from target assessment till complete closure. It may take 3 sessions, sometimes 3.5 sessions also, depending upon how complex or how big the memory network is, which is associated, or how old the memory network is that is associated with the particular memory that we are reprocessing. Now, I will briefly walk through each of the EMDR stages of memory reprocessing. So, phase three, which is called target assessment. So, this phase is where the memory is activated, it is brought to the working memory. And there are some very specific questions that are asked about the memory. So, it is decided beforehand that which memory will be taken for processing. And then there are some very particular questions, such as the worst part of the memory. So the worst part or the image associated with the memory is, or picture associated with the memory is to activate the visual or the auditory, the sensory component associated with it. Let's say the worst part of the memory is, let's say, an image associated with the memory, or the worst part of the memory is, let's say, a particular word or a phrase that was told to the client. So sometimes clients may say things like, I still remember when I think of this memory, the worst part is that my mother called me the most useless child in the world. Okay, so that could be the worst part. So it could be a dialogue, or it could be an image, it could be the feeling, it could also be a feeling. So whatever the client decides, whatever the client chooses as the worst part of the memory, then we assess the negative cognition associated with the memory. We ask the client that when they bring up the worst part of the memory, what are the words, negative words that uh, describe how they are feeling about themselves now. So to bring up the negative cognition about the memory, that I am worthless, I'm helpless, I'm good for nothing, I have no agency, whatever is the negative cognition associated with the memory. Then we also try to bring up an alternate positive cognitions, that what would you like to believe about yourself instead. So that is to bring up a positive cognition, that I would like to believe that I was just a child, or I would like to believe that it was not really my fault, or I would like to believe that I am a good child, actually. So whatever is the desired positive cognition. Now, at this stage, usually because the memory hasn't yet been reprocessed, they may find it very difficult to come up with a positive cognition. And even if they bring up the positive cognition, the degree to which they believe in that positive cognition may actually be very low. They may not really believe in that positive cognition. So we also check for the degree of belief in the positive cognition on a scale of 1 to 7, which is called validity of cognition, VOC. And usually, because the memory has not been reprocessed and they are experiencing the distress, the schema or the negative belief is getting activated, the sensations are getting activated, the positive cognition may just feel like a cognition. It may not really be strong enough. Then we assess for the emotions and the bodily sensations as well as a subjective unit of distress. So we try to numerically understand how distressing the memory is. So a number is given to understand the degree on a scale of 0 to 10. Then and after the memory is activated, immediately after that, the desensitization, where the actual reprocessing work happens, that stage is immediately started. So when we are doing EMDR, it is suggested that if we are towards the end of the session, we should never enter phase three, because if we activate the memory, we will not have time to immediately enter into desensitization. So it should happen only when a significant amount of time in the session is left. So let's say in the initial stay part of the session, because phase four has to come immediately after phase three, because we can't activate the memory and just leave it. So this phase comes immediately after phase three, where the memory is activated, wherein the individual is asked to just notice all the content. So we have activated the memory. We have brought the memory to the working memory stage. Now the stage is all set, and the individual is asked to do bilateral stimulation. So if we are, let's say, in an offline session, in an in-person session with the client, do, um, we may encourage them to do eye movement and ask them to follow our fingers. Or if we are in an online session, then we can ask them to do butterfly taps, or sometimes there are other ways. I sometimes in online sessions ask the clients to do eye movements by looking at the edges of their laptop screen. And all of this, what kind of bilateral stimulation they want to use, what are the different types of bilateral stimulation, what are the different speeds, etc. Everything is done in phase 4. In phase 3, 4, everything is done in phase 2. In phase 4, we don't suddenly introduce this. So they just asked to notice all the content elicited in phase 3 while they simultaneously do the bilateral stimulation. So some sets of bilateral stimulation are done. They do, let's say, uh, 25 to 30 rounds of butterfly taps. Then we ask them to pause. There are specific instructions that we give in order to pause. They pause, they give us a brief report of what they are noticing. And um, it's very important to highlight that there's a component of dual awareness. So one foot in past, one foot in present, because we don't want them to get re-traumatized, right? We don't want them to get carried away with the memory. So it is important that one foot remains in the present, and the bilateral stimulation helps in doing that. The tappings or the eye movement is an activity that they are having to do. It's a somatic activity that they are having to do while the memory has been activated. So we are not asking them to do anything particularly with the memory. It is activated in the background. It has been brought to the working memory. Everything we have asked, all the components, okay, everything, the whole memory has been activated. And now when they do bilateral stimulation, that bilateral stimulation and the fact that they just have to notice, they have to just notice the content. Okay, that keeps one foot in the present, and the activation of the memory keeps one foot in the past. And this dual awareness that they are just noticing the memory, just noticing. And there are metaphors that we use, that as if clouds passing, just notice the content as if you're noticing clouds passing by, or just notice the content as if you're sitting in a train and all the scenes outside are the different scenes that are passing by and you are in a moving train. So there are different metaphors. So when they just notice the content while doing bilateral stimulation, that is when the adaptive information processing network gets activated. And that's when the memory starts shifting. That's when the memory starts getting reprocessed and the desensitization starts. So the activation, like I said, of the dual awareness gears up the adaptive information processing network, which is our inbuilt ability. So as per EMDR, we have the inbuilt ability, and not just as per EMDR. Even in schema therapy, right? We believe that we have that inbuilt ability. We have those resources, and those resources have been tampered because of the different traumas that we carry. And our brain has the ability to create new networks, right? That is what neural plasticity is all about. We have ability, our brain has that intrinsic ability to create newer, more adaptive pathways. So that is what is facilitated over here. And this phase is continued till the distress associated with the memory is neutralized. So till the time the SUD comes down to a 0 or a 1, this phase is continued. And we get to know, when the client, the kind of content that they share while they are reprocessing, when the content starts sounding more and more adaptive, that yeah, now that I think of it, actually it was not my fault. I was just a child and I did not know. My mother should have actually known, or whatever. We slowly start seeing that they start giving more self-compassionate narratives, more neutral narratives, more maybe positive narratives, that actually when I see, I think I'm a very strong person and I have achieved a lot in life. And this is just uh, an old memory. So there are ways in which we also can see that the memory has gotten neutralized. And then when we ask for the SUD, and the SUD is the subjective unit of distress is very, almost 0 or 1, that's when we know that desensitization has been completed. Now, sometimes desensitization can become very slow because the memory has is a big network, and there may be blocking beliefs, or there may be other feeder memories, like other memories that are sort of getting in the way. So then some reprocessing has to be done with those things, and then we come back. Or sometimes the memory is pretty complex and has got a lot of components to it. So then in that case, we may see that desensitization is not really happening, and may take more than one sessions. So then we may have to jump from phase 4 directly to phase 7 incomplete closure. So phase 7 has got two parts. We may have to jump directly from desensitization to incomplete closure of phase 7, park the memory, do some regulation exercises, containing exercises to bring them back to feeling regulated. And then we may have to reopen the memory in a later session, in the next session. So, because the therapist is not entering and the client's brain is doing its own work, it is not like it doesn't happen. It happens beautifully, but sometimes it may take time. Then, once the memory is neutralized, so then we move to phase 5 of installation. So, in the target assessment phase, if you remember, I mentioned that we not just take the negative cognition, we also take a positive cognition, right? So once the memory is neutralized, the goal is not just to neutralize the memory. The goal is also to install a positive cognition and strengthen it. So this is similar to how we do the happy child exercise a lot of times in the imagery work towards the end, right? We take the vulnerable child, we take the little self, little child of the client, child self of the client to maybe their favorite place, ice cream parlor, or to a park. So that is to create a positive feeling, right? So here also, once the memory is neutralized, it is important to install the positive cognition and to strengthen it. So, like I said, it's similar to the happy child imagery to strengthen the positive affect or cognition. And in this phase also, bilateral stimulation is done to install the positive or neutral belief about the self in the context of the memory. Okay. Then, once it is completely installed, we move to body scan phase 6. So, as per EMDR, even after we neutralize the memory and we have also installed a positive cognition, some somatic remnants of the memory may still remain even after the memory has been neutralized and the positive cognition has been installed. So, for example, even after reprocessing and after installation of positive cognition, even after that, let's say the client reports having a little bit of palpitation in their heart or some kind of a heaviness. Okay, or maybe so it is important to do a body scan. So we don't just leave it at positive cognition, we do a body scan. We tell the client to bring up the memory and the positive cognition and then scan their whole body and see if there's anything uncomfortable. So if something uncomfortable, distressing bodily sensation comes up, then we neutralize that as well. Okay, so it could be outside of one's conscious awareness, and it is important to take that also into account. Hence, EMDR deems it important to do a body scan and check for any remaining bodily signs and reprocesses them using bilateral stimulation. And then finally, we move to closure. So closure in EMDR is of two types. One is incomplete closure. So if we have to close the memory because we have run out of time, we have to stop the processing because we have run out of time. There's a separate script for that where we do incomplete closure. And if we have completed the processing, fully finished all the like till phase 6, then we do complete closure of the memory. So to safely, if there is a semi-processed memory, to put safely put put aside the semi-processed memory if processing could not be completed in one single sitting. And then we evaluate how is the client doing, if there is any need for resourcing. And also we evaluate what the client has learned, right? And usually clients come up, so it's basically to consolidate, that what have you learned? What are your takeaways? And they may say whatever they have learned or whatever insights they have developed. And another thing that we do in phase 7 is we tell the client that the processing may continue even outside the session. And they may have insights or, let's say, other images, other memories come up. They can make a brief note. And sometimes I have seen in my work that uh, after the processing, when I meet the client for the next time, they may actually come up with an older memory of the same theme. And then I make note of that memory, and we may choose to take that memory up after finishing processing of the existing memory. Now, how, so far we have understood, we already have an understanding of schema therapy, and we have sort of understood their similarities and differences and what are the different phases of reprocessing in EMDR. Now, how can we integrate EMDR with schema therapy? So, Young, Zangwill, and Bihari in 2002, they have actually written a chapter in a book on EMDR, and the book is called EMDR as an integrative psychotherapy approach. This is the book EMDR as an integrative psychotherapy approach. And in this book, Young, Zangwill, and Bihari have written a chapter. And in that chapter, they have indicated that certain components of EMDR can actually be integrated with schema therapy. And even though it is not empirically researched, they have shared their clinical experiences of integrating certain components of EMDR with schema therapy. So they report that when clients have difficulty accessing different aspects of a memory, the questions from the target assessment phase can be asked to activate the memory and the schemas associated with it. So they have used the example of a client called Dan. They call him Dan, and Dan is somebody who has difficulty in accessing the different components of a memory. So when he brings up a memory, he just brings up a narrative. So probably he has a very strong detached protector. He brings up only the narrative and he's not really able to feel the memory. So what they did was they used the questions from the target assessment phase. What is the worst part or image that represents what is the image that represents the worst part of this memory? They ask him, what are the negative cognitions? So, like, what when you bring up the worst part of the memory, what are the negative cognitions that you have about yourself? They ask him, what are the emotions? And that is when, because there are specific questions, bodily sensations, emotions, etc. That is when Dan was able to activate the other components of the memory, just other than the narrative, the memory got activated, and also the schemas associated with the memory got activated. And then they reprocessed the memory using the imagery rescripting script, but they activated his memory using this. And they have also suggested that resource development and installation can be used with clients while doing schema therapy to build internal resources. And the resource development installation script is a very nice script. In fact, EMDR has got very nice protocols and very nice scripts. Like, for example, the safe, calm safe, calm place script that they have in EMDR. The container script that they have in EMDR is also a beautiful script. They have a couple of scripts in the manual which are really nice, like the spiral technique is there. Some of the scripts are really, really useful. While I personally feel that they're really useful scripts while doing schema therapy to build internal resources. And they have also said that reprocessing of EMDR can be used instead of imagery rescripting. Again, when a client was unable to connect with the emotions during rescripting. So again, with Dan, with a particular memory, they were trying to do the rescripting where they were encouraging Dan to uh, tell his mother in the imagery how he's feeling. They were reprocessing a childhood memory of Dan. And Dan reported that he was saying his mother that, like he was telling his mother what he needs, but he could not feel it. He said that he's just saying it, but he could not really connect to it. He couldn't feel it. So then they went with imagery rescripting, where they just allowed his brain to take charge. And that is when, through the rescripting, Dan kept giving through the reprocessing. They went with reprocessing instead of imagery rescripting. And through the desensitization phase 4 of the reprocessing, that is when Dan came up with material with each set of bilateral stimulation. Now, what I am going to share is integrating components of EMDR with imagery rescripting, particularly with imagery rescripting of schema therapy. And this is purely from my clinical experience. This is not empirically researched. This is not from any study or research that I have done. This is because I'm trained in EMDR and schema therapy both. Sometimes when I intuitively feel that integrating both would be helpful, I integrate them in certain ways. And all I'm sharing is from my clinical experience. And I'm using a case example to highlight how I went about it. So I choose to call this client Anil. And Anil, so it's a pseudonym. So Anil, he is a 51-year-old male. He is of Indian origin. And he's a doctor by profession. He's married from past 25 years. And Anil has been in therapy with me from almost past 4 months. So Anil has a disturbed marriage, and he describes his spouse as quite dominating, disrespectful towards him. And he says that she gets easily angry at him. He feels disrespected uh, with her. And he shares that he does not wish to be in the marriage, but due to societal pressure, and also because his spouse does not want to discontinue the marriage, he is in the marriage. He feels quite helpless actually, and they have a 23-year-old son who is pursuing his master's in engineering. He hasn't yet individuated from his parents. He lives with them. The son lives with the parents. And Anil has shared that he does not want to make the divorce process ugly. So he wants to separate only if the wife consents to separate, not otherwise. But he does strongly believe that they would be better off without each other. But but the wife she doesn't agree. She is financially dependent on him. Anil is willing to support her even after the divorce, but due to different kinds of like cultural and societal pressure, she does not want to discontinue the marriage, and Anil feels very helpless because of that. Anil has shared with me that he has had a difficult childhood wherein he was raised in an impoverished environment, and he describes his parents as dominating, controlling, and abusive when he was a child. When I did his schema evaluations using YSQ and SMI, I found that Anil has high emotional deprivation, social isolation, emotional inhibition, self-sacrifice, and unrelenting standards schemas. And his detached protector mode has also been quite prominent in the session. In fact, his emotional deprivation schema makes him feel that even I cannot adequately meet his needs, and even I cannot adequately be his therapist. So why share much with me anyway? And his unrelenting standard schema also keeps showing up in therapy, where he keeps talking about how he tries to be very perfectionistic in his work with his clients. He's quite demanding towards himself. And so these are like some of the main schemas and modes that he presents with. And so my work with Anil has been a big amount of my work has been in understanding and doing some work with the emotional deprivation schema, because this schema stops him from even trusting me, and stops him from this schema combined with his detached protector mode actually stops him from expressing his emotions. So he talks about things, but he doesn't really express. There's like always a smile on his face, even when he's talking about distressing things. And I've also done some work with his unrelenting standard schema. Now, how I integrated EMDR with imagery rescripting, I'm going to share by means of giving an example of a particular session with him. So, in one of the sessions, Anil was describing how his wife woke him up in the middle of the night because she wanted to talk about all the problems in their marriage. And he reported that he actually wanted to sleep. He was very sleepy. He said he wanted to be assertive. He wanted to tell her that he's sleepy, but he could not. And he felt helpless and suffocated. So I used Affect Bridge, and using the Affect Bridge, Anil was able to report a memory in which he was 8 years old. And in this memory, he recalled his mother scolding him badly for something. He said he clearly recalled that she kept talking nonstop, and he wanted to escape, but he was unable to do so. He said that he was able to clearly recall these aspects. And he remembered feeling quite suffocated and helpless in this memory. So I did imagery rescripting with the memory, following the usual steps of imagery rescripting in schema therapy. I entered the memory. I told him to narrate the memory in first person, and the way in which we like work with schema in schema therapy. And then I entered the memory to support little Anil and to confront the mother firmly. And I firmly told her to be kind and gentle towards him, and that it is not okay for her to scold him, etc. Now, this was the first time when Anil was actually able to cry in the session. He cried profusely while I was doing the imagery rescripting with him. And he reported feeling supported, validated. He said he was feeling bad for his child self, but he also felt supported and validated. And then I made Anil come back to the memory of his wife talking to him late in the night. And he was asked, how does he see himself handling the situation now with the resource of feeling supported and validated? And he was able to imagine himself being assertive. Wife, he told her that I want to sleep. Can we talk about it tomorrow? I will be in a better frame of mind to listen to your concerns tomorrow, because right now I'm very sleepy. I will not be able to process, etc. So he was assertive with her in the imagery. And this is where I subtly introduced the installation phase of EMDR, phase 5. That's where I introduced it. So I asked Anil, as you imagine being assertive. So I modified the wordings a bit, but I felt that this resource of feeling supported and validated, and how he was being able to be assertive with his wife, needs to be consolidated. It needs to be strengthened further. So I asked Anil, as you imagine being assertive with your wife, what does it say about you as a person? And he reported that I'm learning to be assertive. And then the validity of cognition was taken by asking how true it feels on a scale of 1 to 7, where 1 is completely false, 7 is completely true. Anil reported it to be 5. And multiple sets of bilateral stimulation were done to strengthen the positive cognition until it became a 7. And then I did a body scan also, um, along with bilateral stimulation till the body scan was clear, though he did not report much distress in the body, but still some rounds of bilateral stimulation were done. And uh, towards the end of the session, Anil reported that his major learning from the session was that I am learning to be a valuable person. So, why this was done? Why did I think of integrating? Uh, and it's not like I did the entire reprocessing using the EMDR script. I did the reprocessing using the imagery rescripting method only. But when he when I made him come back to the present with the resource and made him use the resource, that is something that has to be strengthened. That is something that I felt that it is important to stay with it. And it might also be not just important to feel supported or just do it and feel assertive. It was important to stay with that healthy adult resource that he developed because his child self felt supported, validated, and his adult self using the resource of support and validation was able to exercise um, assertion, was able to be assertive with the wife in the image, in the imagery. And I felt that it is important to install that. It is important to consolidate that. It is important for him to stay with this for some time. And his adaptive information processing network should be allowed to like really strengthen this positive cognition that I'm learning to be assertive. And it's important to have a phrase with, that indicates it. So when I did phase 5 and asked him that, what does it say about him as a person? That's when he was also able to reflect and come up with a particular statement. And then it was strengthened. So this is how I looked at it. And towards the end also, he was able to give a significant learning. Now, following this session, Anil reported feeling less helpless with respect to his relationship with his wife, and he reported being able to be assertive with her. He reported feeling more empowered, reported that his wife has started becoming relatively more respectful towards him. They were also in couples therapy simultaneously. And I think it was probably a combination of both the things. And I also noticed that Anil had started opening up more. He had started allowing himself to be vulnerable in front of me, started allowing himself to be more expressive towards me. Initially, Anil used to be quite a counter questioning client where he would like pretty much question most of the things that I would say. But after this session, I noticed a significant breakthrough. I felt that Anil started trusting me more, started allowing himself to express more in front of me. Uh, Now, I have also used EMDR to strengthen the healthy adult, certain components of EMDR to strengthen the healthy adult. So, while we attempt to work with the early maladaptive schemas and the modes, it's of course also important to strengthen the healthy adult or even other positive experiences as and when they show up. So, we may have a client may bring up a positive experience to the session or an experience where they were able to use the healthy adult meaningfully, where they've like functioned from their healthy adult instead of functioning from uh, any other maladaptive mode or their schemas. When they show that, it is important for us to consolidate that. I think it's important for us to stay with that. Or they may have positive experiences with others, experiences which may reshape their belief system. So it's important to stay with those experiences as well. And I sometimes use the resource development and installation protocol of EMDR to strengthen these experiences. And I'm again going to give a brief case example of how I have used it uh, by talking about a particular client and a particular session with the client. So, Gavi, I choose to call the client Gavi. Gavi is a 35 years old female. She is unmarried of Indian origin and she works as an architect in Germany. She has been in therapy with me from about the past 8 months for difficulties related to self-esteem, low mood, and loneliness. Now, Gavi has had two breakups over a period of 6 months. When we started therapy, that's when she had also started seeing somebody, but very soon it broke up. They broke up. And after a few months, she was again seeing somebody, and then that also unfortunately did not work out. So there were two back-to-back breakups just over a period of 6 months. And Gavi also has a history of an abusive romantic relationship that she came out of about 2 years back. And she has been having significant self-doubt after these two breakups and feels like she's a difficult person. So she has also her critic boards have gotten activated and she keeps saying that I think I'm a difficult person to be with. Gavi has a strong emotional deprivation, abandonment, failure to achieve, and unrelenting standards schemas. And Gavi has described her childhood that during her childhood, her parents were either not emotionally available or when they were available, they were very critical. And she would feel ashamed if she would not perform well academically. So Gavi has been a very bright student academically, but then the parents abruptly relocated to another city, changed her school, um, and in the new school, the curriculum was different. She started having difficulty in adapting to the curriculum. And then the reason why the parents had shifted to the new city did not work out for the parents. So they relocated back to the city where they were earlier in, and they put her back to the school where she was earlier in. But then Gavi started having difficulty adjusting to her previous school because some of her friends had made friends with other people. And because she was in a different school and in a different kind of curriculum, she found it difficult to suddenly catch up with this curriculum, and her performance started declining. The parents were not really available to help her academically. They were not even emotionally available. And if she would take help from them, with respect to her academics, either they would not help and they would just criticize and shame her, or they would help and also criticize or beat her up, physically punish her. So it had become a very difficult experience, as she describes. Now, in one of the recent sessions, Gavi was describing an experience with a climbing instructor. So Gavi has recently, from the past 5, 6 months, taken up a hobby of climbing, where so she is at the basic level and she wanted to take up some training for advanced skills. So she was talking about an experience where she had enrolled for an advanced skills class for climbing, and the climbing instructor refused to teach her advanced skills as, according to the instructor, she needed more practice with the basic skills first. And he told her to practice consistently and come back for the advanced skills in 3 months. Gavi reported that even though the instructor was polite to her, in fact, she clearly said that he was saying that I cannot teach you advanced skills now because you need more practice with the basic skills practice and then come back and enroll in the next round of advanced skills. She said he was saying that, but I heard that you are a loser, you are good for nothing, you will never be able to do anything in life, you are so pathetic at climbing. And she was able to make that distinction that he said something else, but I interpreted it as something else. So she felt like a loser. She almost started feeling abandoned. And on her way back, she reported that she cried profusely on her way back home. So her failure to achieve schema as well as her abandonment schema got activated. Now, on her way back, Kavi called up a friend and she shared this whole incident with a friend over phone, who she reports that he validated her, he supported her, he said that, oh, this sounds bad. And he was there with her throughout the phone call. He encouraged her to practice. He said that, okay, don't worry, we will practice together and I will help you do the practice. And it's okay, I understand. I'm right here. I can meet you if you're feeling distressed, etc. So he said a bunch of like really validating and supportive statements. So though Gavi felt deeply supported and grateful towards the friend, she also found the validation very strange and she reported hardly having experienced it. And this made her very emotional. So even in the session, while she was talking about it, she said that while I feel very grateful and I feel very supported, it's very strange. I was surprised that people can also respond like this. And she was quite emotional about the whole experience while she was having feelings of gratitude as well. So I thought that it is important to strengthen this experience. I mean, of course, this experience was in itself very powerful, but I thought it's important to stay with the experience and to like really foster these feelings of feeling validated, cared for, supported. And I used the resource development and installation protocol. So I did not have to develop the resource because the resource was given to her by somebody. So it is not like I had to develop the resource. I just had to strengthen the resource. So I had to install the resource and like really strengthen different components of the resource. And I used that to deepen and strengthen this feeling because Gavi very easily feels invalidated, very because of her schemas, her like she starts feeling that maybe I'm not important or I can easily be abandoned. And she starts feeling um invalidated, inhibited quite easily. So I thought that it is important to validate to strengthen this particular experience because this experience would also lead to adding a layer of self-compassion and foster her attachment system, foster her attachment security. So I asked her what image represents this resource. So the initial part of the RDI script talks about identifying the resource and developing the resource, but I didn't have to develop or look for the resource. The resource showed up and I had to strengthen it, deepen it, strengthen it. So I asked her what image represents this resource. She said that it felt like he was being an elder brother to her. And then I asked her, as you bring up the resource of feeling validated and cared for, when you spoke to your friend about the climbing instructor incident and your experience of it now, what are you feeling? What emotions are you having? What sensations are you noticing in your body? So it's the script that is mentioned in the manual. Gavi reported feeling very grateful for the support. And this experience was strengthened with some sets of slow bilateral stimulation. So when we are strengthening something positive, and when we are only strengthening something positive, not in collaborate or not in the context of a negative memory, when we are just strengthening something positive, that is when slow bilateral stimulation is used. That is what the manual says. Now, through the sets of BLS, Kavi reported, so through these sets, Kavi kept reporting different things. She reported how the friend not just validated her, but also helped her find the solution, offered to help with the solution. So she said that he gave me the solution and he also told me that here is how we can uh, use or do the solution. Like he came up with the solution and also told me how to apply that solution, offered to help with her. She felt good. She reported valuing the friendship and finds it deep and meaningful. She also reflected on how it is okay to ask for help. She reflected that she actually doesn't ask that much for help, but how it is okay to ask for help. And then once the resource was internalized, I asked Ravi, is there a cue word or phrase or positive belief that represents this resource? And Gavi said that what came up for her was, I am worthy to be cared for. So this cue phrase was further strengthened with slow bilateral stimulation followed by self-cueing. So Gavi was told that she can actually use this to remind herself that she is worthy to be cared for when she's in distressing situations. I did not do the future template of, so in RDI, there is also future template where the same, so the after the resource is developed and installed, they are asked to go back to the situation where they think they needed the resource and ask them to imagine how they would see themselves using the resource. So I did not do that. I skipped that because it is not like I developed the resource. So that is why I did not go back. I just like stayed with strengthening the resource. And towards the end of the session, Ravi reported more self-compassion. She said that she would plan how she can practice with friends, and she shared the plan with me. And she also was able to now understand the instructor's point of view. She said that, yes, now I understand why he asked me to come for advanced classes later, because in advanced you are taught how to rescue somebody else and taught how to be behind somebody to rescue them in case they fall. And if my grip is not strong and if I am not able to practice the basics itself properly, I am not just endangering myself, I'm also endangering them. And I see the instructor's point of view. So Gavi was able to come up with these insights. Now, to conclude my presentation, of course, both schema therapy and EMDR are very powerful in their own ways. And integrating some components of EMDR in rescripting, in my clinical experience, not just deepens the impact of the rescripting, but it also fosters a categorical positive cognition. Like we saw with Anil, that I did the rescripting and then I also helped him come up with a positive cognition. So it not just deepens the impact, but a categorical positive cognition, like a takeaway, something which is very specific. And that can be a strong takeaway for the client, especially with clients who are very critical of themselves. Having a proper, strong, categorical positive cognition can be helpful. So the bilateral stimulation used in EMDR is a powerful anchor that keeps one foot of the client in the present while also engaging the working memory. So the bilateral stimulation has a twofold function. It keeps one foot in the present because there is an activity, a somatic activity that the client is having to do, like the client is having to follow the fingers or do the tapping. So there is something at a somatic level that their body is doing. So they are in the present. And that also engages the working memory because they have to remind themselves that they have to do this. They have to do the tapping or they have to move their eyes. So this dual awareness fully activates the adaptive information processing network, thereby leading to better consolidation of the new positive belief or experience. So, like we saw in the case of Gavi, that when she came up with a positive experience and I strengthened them using bilateral stimulation, strengthened it using the RDI protocol, it helps to consolidate. So whether it was Anil with whom I used the bilateral stimulation to strengthen the positive feeling of being supported, validated, and being assertive, or whether it was Gavi with whom I helped her to strengthen an actual positive experience. In both the cases, Bilateral stimulation really helps to ground the client and also activates the adaptive information processing network. So, this was about my clinical experience of integrating imagery rescripting with EMDR, or how I integrate EMDR with some other components of schema therapy. And yes, thank you for patiently listening to my presentation. And much gratitude to all of you, and much gratitude to ISST for coming up with such a beautiful initiative of World Schema Therapy Day. Thank you. Take care of yourselves. Stay well.